Hi, today we will have our lecture about the arch anomalies, when to suspect. Okay, for my lectures I hardly introduce the embryology. It's nice to know about the embryology, but I think we complicated the things if we started by the embryology. But in the arch anomaly, it's one of the lectures that I thought if you understand how it comes, the embryology of the arch, how the arch developed, it will be easier to understand what is the arch anomalies. So to start, this is how we look for the arch, for the aortic arch. We thought it's like that, but actually it is like that. What is the difference? This is colorful and the other is not, but each color of that means different origin in the embryological development of the aortic arch. In the literature you find this movie. When first time I saw it, I found it very complicated, but we will go through it to understand what it does mean. Okay. We will not go through when by the fetal life and gestational age, when does it start or not. I'll skip this part, but roughly I will say you have an ventral or anterior aorta, and we have dorsal or posterior aorta, and both of them are communicated with arches. Is that easy? So anterior and posterior aorta, and both of them are communicated by arch. So we have the first arch, right and left, and we have the second arch, right and left, and we have the third and fourth. Okay? It's easy. So we have an anterior and we have a posterior aorta, and communicated by arches. So the first and second and third and fourth. First and second disappeared. So it's not with us in the embryological development. Now we have the third and fourth, this purple and yellow color, and you expected the fifth, right? But fifth does not exist in human. So we have the first and second, third and fourth, and we have the sixth. So sixth is of particular importance here. This is the sixth arch. And the sixth arch is connected, the dorsal aorta, with the pulmonary bed. So you have the sixth aorta. So did you expect what will the sixth aortic arch will be?
BDA.
A BDA. It's a connection between the aorta and great. So we have here the sixth aortic arch connecting the dorsal aorta with the primitive lung bed. We have the right and left. And we have intrasegmental arteries. The sixth one, in some literature they said the seventh, so the sixth or the seventh, here you will find it connected with the dorsal aorta. Is that clear? So we have anterior aorta and we have the posterior aorta. We have arches connecting both of them. First and second does not involve in this arch embryology. We have the third and fourth. Fifth does not exist in humans. So we have the sixth, and sixth connected the dorsal aorta, posterior aorta with the primitive lung bed, not with the anterior. And we have here from the intersegmental arteries, we will focus on sixth. What will happen after that? That this at the connection between the third and fourth, this segment will disappear. Is it clear? And now the sixth aortic arch on the right side will start to diminute and eventually will vanish, but the left sixth will persist. And look here, I kept the sixth intersegmental artery at the same place, but where is the artery? If you look back, the artery was here, and he creeped cranial, he creeped up, and this was the original place, but he creeped, he moved up. What will happen after that? The sixth arch completely on the right side disappeared, and the sixth intersegmental artery creeped more above. So again, this is the anterior, this is the posterior, and we had arches, the first and second is not in this story. Third one, fourth one. Now the area between the third and fourth is completely disappeared from the posterior one, and we have the sixth arch, the right side eventually vanished from the stool. Okay, go forward. Now, the right side, it's completely disappeared, and the sixth intersegmental artery continued to creep above, and here is going, and this is the arch that we see in the first place with colors. A bit complicated, but if you understand that this aortic arch is not a homogeneous structure, it's a heterogeneous structure, so you can understand the expected pathology or expected anomalies in that arch. Okay. If we say here, this carotid arteries, the base of the carotid arteries is contained the third aortic arch and the part from the posterior. And here, part from the arch came from the fourth aortic arch, and part from the base of the subclavian came from the fourth aortic arch with the intersegmental artery that creeped above. If we stopped here, does it ring any bell why sometimes the subclavian artery have an apparent origin? Because it originally does not start at this place. It's creeped from caudal to cranial, so it might stop at any time. Okay. And this is the BDA, the persistent sixth aortic arch on the left side. And this is subclavian from the intersegmental arteries. So the aortic arch embryology is a bit complicated, and it's a heterogeneous structure. So we can think about the embryology to remind us with the pathology that we expected that's there. Any question about the normal arch? It's a long story, but we can make it short. Anterior and posterior aorta connected with arches. First and second does not include in this story. Third and fourth will present. There is no fifth aortic arch in human. There is six, right and left, connecting the posterior aorta with the lung. And we have intersegmental arteries. The sixth one will be in the story. By time, the connection between the third and fourth will disappear. So the third will be in the neck vessels, the carotid, and the fourth will be part of it in the arch and part of it in the subclavia. And by time the six intersegmental arteries will be high up at the level of the arch, and by the time the right dorsal aorta will disappear. So we will have this arch. Okay. In the literature, this one that we have seen it, another view, if we cut cross-sectional area. So this is the descending aorta or posterior aorta, and this is ascending aorta. We have here the carotid that it comes from the third aortic arch and the posterior one, and we have here left and right, and here the subclavian artery that is mainly from the six intersegmental arteries from it. And we have here the fourth aortic arch, right and left, right? So if you would like to have the normal left-sided aortic arch, what it should happen, as we said, this one will disappear from the story. So we will have the ascending aorta, we will have the brachiocephalic giving the right carotid and right subclavian, and we will have left carotid and left subclavian, and we have the ascending aorta. So we have here left aortic arch. This is another cut view transverse for the story that we said. If you'd like to remember any of this, that we have an ascending aorta, we have a descending aorta, and we have this circle by the fourth aortic arch giving carotid and subclavian in each side. Okay. We would like to talk about the fetal circulation. This is the ascending aorta. Ascending aorta giving the blood supply to the head, but the descending aorta and the lower body from it, depending mainly on the isthmus, which have a blood supply from the duct. So actually 75 of the blood flow in the descending aorta and the lower body is coming from the duct, not from the ascending aorta. Keep it in mind until we need it. So the flow theory here, that the flow during the fetal life, depend mainly on the duct to supply the descending aorta and supply the lower body. Okay. If we talk about the arch anomaly, what comes in your mind? Say something, Mohammed. Arch anomaly, just to give an example.
Failure of absence of any of
No, I mean clinical scenario. What is arch anomaly? What include under this title? Corcutation, double aortic arch, apparent subclavian, interrupted aortic arch, double aortic arch, we might say it. So a bit it's confusing. So we can enumerate all of that. So if there is any classification. So if I say that there is an aortic arch anomaly, there is any classification. Actually, first time Dr. Wael asked me to give a lecture about that, I felt that it is scattered all over the place. So sometimes you have like a vascular ring, a double aortic arch. Sometimes we are talking about corcutation. Sometimes we are talking about interrupted aortic arch. I felt that it is all over the place. Then when I looked in the literature carefully, I found that we can classify them to two classifications: anatomical abnormalities and the flow abnormalities. In the anatomical abnormalities, simply that persist of a segment that should be regressed, or regression of a segment that we expected to be present. Again, that's why I think that morphology, if you spend some time in morphology of the arch, all the anatomical abnormalities will be explained in your mind in an easier way. So from this story that we admit that aortic arch is a heterogeneous structure, and a lot of segment we expected it to be regressed in due time, and we expected another segment to be presented. So if any abnormality in that process, that a segment that should be regressed present, or a segment that should be present regressed, we will have an anatomical abnormality. The flow theory here, any lesion that results by decreased antegrade blood flow through the isthmus. So again, we are not talking about the valve, aortic valve or ascending aorta. So if there is any condition that the blood flow through the isthmus, which comes from the duct, decreased, we will have abnormality in the isthmus, in the mid aorta, or we have interrupted segment in that. So this is the causes of arch anomaly. Either it's anatomical abnormality, regression of a segment that should be possessed, or present of the segment that should be regressed, or flow theory that the isthmus does not supply enough blood supply to the descending aorta. Okay, we will talk first about the anatomical abnormality, and actually it will be a fun. We will just have this cross-sectional area and we think with each other what we expect for that. For anatomical abnormality, we will have abnormality in arch position, or we will have supranumerosity of the arch, that we have an extra arches that is present in that, or we will have abnormality in branching pattern other than the normal. In the flow abnormalities, we will have obstructive lesion. All of them, none of our patients suffer from increased blood supply to the descending aorta. All of them will suffer from decreased blood supply in the isthmus. So we will have the obstructive lesions in that. We will enumerate them later. Okay, we will start by both of them, by this classification, but for practical, we will talk about how to image an aortic arch. It's by echo. And usually this is a forgotten part in the adult echocardiography, that they forgot how to look for the aortic arch. How they do it? By suprasternal views. We have suprasternal views by echo. longitudinal and axial for that. I will go in details for that because this is important and actually it's forgotten practice in the adult cardiology. However, all the pediatric cardiology know how to do the suprasternal views. So to have good suprasternal views, it is supine position for the patient with head support, chin up, or put something under the shoulder so you have a good exposure for that. You will put in Anglus of Lewis, and we have two suprasternal views, depend on the knob or the light or the edge in your probe, how do you put it. So the first one is short axial view. Short axis view, you put your knob in that position. You look for here, this is a good exposure for suprasternal position, so the patient lying supine with support under his shoulder, so and he's looking up, so actually this is a good exposure for suprasternal view. And here the knob putting transverse at the 3 o'clock, for example, if you have in mind at 3 o'clock position. And this is the movement by the probe, anterior and posterior. What do you expect to find in that view? So this is cutting this structure. This is superior vena cava and the innominate vein. You will find it like that. And this is the aorta. Aorta cut it perpendicularly on the arch. That's why we call this suprasternal views short axis. It's short axis for the aorta. So we will have the aorta like structure. And this is the right pulmonary artery, and this is the left atrium with pulmonary veins. This is a crab view because all the pulmonary veins coming to the left atrium in a crab view. And he has its name from the aorta. So you see here the aorta. This is superior vena cava, and this is the innominate, RPA and the LPA. Okay, clear that view? Short axis to suprasternal view. Okay. The second view will be the long axis. The knob now is perpendicular on the other view, so the knob at 12 o'clock position, and here this is the probe, and we move to the right and to the left. So this is vertical view, and we move to the right and to the left. This is how we cut the aorta. We cut the aorta in the longitudinal because this is the structure, so you cut the aorta in parallel way. So you have the aorta in the long axis, and you have here the RPA. This is how it looks like. Is it clear? So echo is our imaging modality. It's bedside. You have to focus on suprasternal views to the image the aortic arch in that. Okay. If we need extra or cross imaging, TEE is not an imaging modality because aortic arch is a blind spot for in the TEE. So if the echo is not enough, don't ask for transesophageal echo. Arch place is a blind spot for the TEE. So TEE is not of use. Cross imaging, you have multi-slice CT and you have MRI. Both of them can give idea about the aortic arch and can help us a lot with this abnormality. In brief, not in details, multi-slice CT have a better spatial resolution, so you can see the anatomy of the small structure in a good way. Multi-slice CT have a better spatial resolution compared by MRI, but the cost is the radiation, and the cost is that you give ionic dye for that. If you have a baby with question about the arch that not being solved by echo, so your imaging modality is multi-slice CT. Because the babies are small and the aortic arch will be small, so the multi-slice CT is the option to image them. In adult, you can use cardiac MRI because the aorta will be bigger and you don't need a higher spatial resolution. MRI will be okay. MRI for the anatomy is okayish. You got good images by cardiac MRI. Advantage is without radiation and without ionic dye. MRI have an advantage over the CT for functional assessment. So if you like to assess the LV function the hypertrophied, or the flow assessment, MRI is your imaging modality. We will see it coming by that. This is CT and MRI. So here, higher spatial resolution by CT. You can see all the details of even the smallest structure. So it is point for the CT. MRI have a point for evaluation of comprehensive study for the function, in addition to flow assessment when it's needed for that. Okay. This was an introduction for the lecture. We will go now again by the abnormalities in the aortic arch. We will go type of the abnormality, cause and morphology, when to suspect, rule of imaging, focusing mainly on transthoracic echo. We ask ourselves when we need an extra cross imaging modality. Okay. We'll start now by the anatomical abnormalities. Abnormalities in arch position is two. Either we will have right aortic arch with mirror image instead of left aortic arch, or we will have cervical aortic arch. Okay. This is the right aortic arch. Back again to our cross-sectional. That's what we expect to have in the left aortic arch. That we have regression here in the fourth aortic arch between the anterior and posterior aorta on the right side. It ended up that the arch will be left, and this part will be brachiocephalic. Think about how can we have a right aortic arch. It is segment that it regressed and should be present, or a segment that present and should be regressed. So think about how to make this one a right aortic arch. Yeah, I give you 1 or 2 minutes for that. Would like to? We will make it a rotation. You would like to answer?
Yes, we're going to say persistence of right fourth aortic arch.
Okay, this one should be back.
Yeah.
But it will be double arch.
Yeah.
So something have to be regressed.
Regression of the left.
Exactly. So here, this segment will be back. This segment will be back, but here we have double arch. And yeah, this is an answer for a question when I ask about the double arch. So if the segment that should be regressed present and nothing happened, it's double aortic arch. But we are talking about the right aortic arch with mirror image for the neck vessel. So it should be regression of this segment, and here the arch will be right, and all the branching pattern will be mirror image. This will be the brachiocephalic with the carotid and subclavian, and here we will have the right carotid separate from the right subclavian. Is it clear? Okay. This is the embryology. Actually, right aortic arch is no symptoms discovered accidentally during routine echocardiography. We suspected that in some patients, like tetralogy of Fallot, 25 of our patients have it. And by default, if you have situs inversus totalis, that everything is going to the other side, so your arch will be right with a mirror image. Okay, how to discover it? By echo. Okay, this is short axis for short axis 1. You don't see the aorta in the long axis, but this one is modified. In the short axis, as we said, that we move anterior and posterior. The knob is to the 3 o'clock position, so we move anterior and posterior. Here we have the aorta as a circle, and we have here the first branch that is bifurcating to 2. It's a rule of thumb that the first branch bifurcating in the opposite side of the arch. So I find it here that I have the first bifurcating branch to the left. The arch is the opposite side from that. So if I find it's a bit how that you look for that. Have short axis aorta and angulate your probe anterior and posterior. You will find this first branch bifurcating into. If I find the first branch is not bifurcating, what do I expect? I expect an apparent subclavian. If I find the first branch bifurcating to the left, we will have arch right. If I find the first branch bifurcating to the right, so I expect the arch to the left. But what if I find the first branch does not bifurcate? We will have an apparent subclavian. Something to keep in mind for the next. Okay. Okay, this is the aorta, and the flow here in the first branch is red because the flow is going to the head, so it's coded red. Okay. We don't need to do anything for that patient, just accidental finding, but it's common and it's associated with many congenital heart disease, so you expect it to find the red. Okay, cervical aortic arch. Okay, the normal position here in the aortic arch, it will be behind the sternum, not above it. So actually it is here behind the sternum. In a rare anomaly characterized by high riding elongated aortic arch, abnormal persistent in the second and third primitive aortic arch. You remember that the second aortic arch, it will be included here, the primitive, ascending in the neck usually to the right. So this is actually the clavicle of the patient, and you will find here the aortic arch. How can I suspect that clinically? You will find a pulsatile mass in the neck, and if you compress in that on that mass, the patient will be fainting, or you will find absent in the pulse in that. So actually it's very prominent, it's very rare condition, but you will figure it out if you face it. It's pulsatile mass in that. Actually by echo it's very difficult because it's a rare condition, but we will happen here. We have here the superior vena cava, and we have here the right RPA, and we have here a structure that we don't know if it's a circle, if it's a longitudinal, but we find here a pulsatile structure. And here by echo, you will find something funny, that you are not able to trace this structure, and you will find a pulsatile mass beside your probe. Here the rule of multi-slice CT, attractive and beautifully explain what happened here in the aortic arch. Again, cervical aortic arch is a very rare condition, but you understand what happened, that one of the primitive aortic arch present this cervical arch. Okay. Now we will move to number 2, supranumerosity of the arch. So supranumerosity of the arch, you will find that you have a BDA or double aortic arch. It's very easy to expect where BDA comes from. From which arch? The 6-1. 6-1 will be persistent. So now we have the 6 aortic arch on the left side persistent, and it will have the duct. Okay. Again, it's failure of regulation of the 6 aortic arch on the left side. BDA is common lesion in the pediatric group. It can be isolated lesion. It can be duct dependent for pulmonary or systemic circulation, as we said in many of our lectures. It could be small isolated lesion, so it's not symptomatic. The patient will be discovered accidentally to have by murmur and can go for the adulthood, or to have a big duct and you have volume overload and congestive heart disease. I think one of our colleagues, Omar, have a lecture about the BDA and how to close it. So it's very common, but you now understand it's failure of regulation of the 6 aortic arch on the left side. Again, it's an easy task. This is a short axis echo. So we have here, this is not suprasternal, this is a short axis. So we have here aorta and we have here pulmonary. This is the right one. And on the left one, you find a red flow coming here. This is the probe. So we can explain the blue color that is going away from the probe is going away to the lung. So it should be coated in the red, in the blue, I'm sorry. And for this flow that's coming, the red one, so it means that the blood is going from down to inside the pulmonary, and this is the duct. Another view here that you find the flow, and this is the flow of the duct by Doppler. It's continuous flow because all the time the blood pressure in the aorta is higher than the blood pressure in the pulmonary during systole and during diastole. So the blood will go with a gradient from continuous. So always you have a continuous flow between the systole and diastole in pulmonary, and between the aorta and pulmonary in systole and diastole. So you can measure the gradient as we explained by Bernoulli equation and that. But this is the way how to detect a PDA. Okay, cross imaging is also useful to detect it. Again, we depend mainly on the CT. So we have it here. This is the pulmonary and this is the duct, and you can measure on top of it the measurement like Omar explained. CT and the catheterization, both of them can do the same function. It depends on the interventional guys if you'd like to have a plan as a roadmap or do it in the cath lab. But both of them can be alternative methods in that place. Okay, we'll go now to double aortic arch. This is what we expect to have a double aortic arch. We answered it earlier, but what we expect to have?
Resistance of right dorsal
fourth, and nothing happened. So we will have double arch, and each arch will give two neck vessels, the carotid and the subclavian of that side. Okay. If you have double aortic arch, this one of our vascular ring is a ring of the blood vessel that's circulating the intrathoracic portion of the esophagus and trachea. So we will have both aortic arch encirculating the trachea and the esophagus. And if the patient is symptomatic for that, usually with double aortic arch, the patient are symptomatic. So division of some parts of this vascular ring will relieve the symptoms of this patient. The clinical presentation, how do you expect the patient with double aortic arch to be present? It depends on the respiratory symptoms and feeding symptoms. So the usually is early presentation if this is significant vascular ring. So in respiratory symptoms, you expected to have inspiratory stridor, wheezing, chronic cough, recurrent respiratory infection, hoarse cry, feeding also. The patient have failure to thrive, dysphagia, or shocking due to the compression on the esophagus. On physical exam, you will have poor weight gain if severe compression, and on pulmonary examination is wheezing, stridor, or dyspnea like that. Okay. How do image that in double aortic arch? So actually, in the long axis, as we said, the knob will be at 12 o'clock, and you move to the right and to the left. When you move it to right, you will find an arch, and when you move your probe to the left side, you will find an arch. So this one, arch, and this is a second one. So when you move to the left, you will find an arch, and when you move to the right, you will find an arch. And this is the color, this is the first arch, and this is the second arch in that patient. If you don't find it, you will miss one. You will miss one. So actually the exam, if you did move you will find an arch, and you will be satisfied by that you have an arch. Okay. We have a very famous sign by CT. We call it 4-vessel sign. If we back to the embryology, we have said that we have 2 arches, and each arch giving 2 separate vessels. We don't have a brachiocephalic in that. Is that clear why you don't have a brachiocephalic? Because nothing regressed in that vascular ring, so we don't have a brachiocephalic. So we will find on both sides of the aortic arch, we will find separate neck vessels. So each carotid come by itself from the arch, each subclavian come by itself from arch. So we call it 4-vessel sign by CT. Okay, is it clear about that? Double aortic arch is one of our vascular ring. We have 5 vascular ring. We have 5 types of vascular ring. Double aortic arch is one of them. We'll move to abnormalities in branching. So this is how we expect the aortic arch branching pattern to be. So we have brachiocephalic giving the carotid and subclavian here, the left aortic arch. So brachiocephalic will be on the right side, the opposite side of the arch, giving the right and left subclavian. And we expect the left carotid to be like here and left subclavian to be like here. Again, both subclavians, where they come from? 6 intercostal that creep from caudally to the cranial, so expecting an apparent origin for both of them. Okay, we will start now by the apparent origin of right subclavian and left subclavian. If we have a left aortic arch with apparent right subclavian, it will be like that. It's left aortic arch, and we have here the subclavian coming in that way. Okay, this is how we expect our left aortic arch to be. We would like to have this left subclavian posteriorly and not connected and with apparent right subclavian. I'm sorry, this is left aortic arch, and we would like to have this right subclavian. We would like to have it posteriorly, and we would like to have the brachiocephalic given the right carotid arch. So the regressed segment should be retained, right? So the segment from the fourth arch should be retained. Which part from this circle should be regressed to have a left aortic arch and to have this apparent right subclavian? Which part of them from this circle? So this part will be back again, right? But if nothing happened, we will have double aortic arch, right? So some segment in this circle should be regressed. Okay. Shell, تعال قول لي which segment should be regressed. We have a lot of segments.
بقى ال right subclavian هو ال posterior كده.
This will come again. Which segment should be regressed?
كده؟
Yeah, exactly. Between. Okay, this segment should be regressed. Exactly. So we have here a left arch. We have a left arch. We don't have a double aortic arch. Again, this right subclavian now is connected posteriorly, but we don't have a double aortic arch. We have a brachiocephalic that is giving one branch. Again, you remember when I said if you find in the short axis a circle that giving the first branch going to the left, so you have a right aortic arch. If the first branch is going to the right, then you have a left aortic arch. Usually this branch bifurcating. If it's not bifurcating, you expect to have an apparent subclavian. This is the case in that way. Okay. If we have left aortic arch with apparent right subclavian, if the patient is symptomatic or not, it depends on the ligamentum arteriosus, which is the duct that is closed, the sixth aortic arch on the left side that it had been regressed and left a ligamentum arteriosus connecting the descending aorta. Okay. If you have a left side segment, no vascular ring and no symptoms, because this what will happen, that you don't have a complete ring. This is ascending aorta. Now we have this arch, and we have here the right subclavian, and this is the ligamentum arteriosus. So the esophagus and trachea does not have a vascular ring. So all segments are on the left. So the right side does not have any structure to be encircled the esophagus and trachea. Okay. If the ligamentum arteriosus is right, and this is very rare, so we have here a ligamentum arteriosus. So we have a complete circle around the trachea and esophagus. Here the aortic arch. We have ascending aorta. Here the aortic arch. Here is the apparent right subclavian, and here the ligamentum arteriosus. So the circle is complete around the trachea and around the esophagus. We said the vascular ring. This means that the circle of blood vessel, and we consider ligamentum arteriosus as regressed blood vessel. So actually, this is the complete cycle. Ligamentum arteriosus is not a structure to have a dye in the CT or MRI. So actually, you will not double aortic arch. You will see the contrast in the double aortic arch, but in this condition, you will not find the contrast in the ligamentum arteriosus. We depend on the indentation on the trachea to delineate that we have a vascular ring at that side. So it's a bit tricky, and you have to look carefully for that. If you have a left-sided aortic arch with apparent right subclavian, actually ligamentum arteriosus will be in the left side in most of the cases. But if you find indentation on the trachea, consider that a complete vascular ring. So complete vascular ring, in that case, does not mean that you will see blood all over the expected circular expected ring, because part of it is ligamentum arteriosus. Okay, we have the same story again with right aortic arch with apparent subclavian. This how we expect to have a left arch and with normal branching. Now we would like to have a right aortic arch and the left subclavian to be on the posterior side. So again, this part will return again, right? Now we have a right aortic arch, but still we have the other arch. So this connection should be happened in that area, exactly like the same before. So now we have a right aortic arch, and we have here the first branch is going to the left, but giving only the carotid, and subclavian is connected with the posterior. So this is what we have here. We have a right aortic arch, we have apparent left subclavian. Okay, symptoms depend on the site of the ligamentum arteriosus. If you have right aortic arch with apparent left subclavian and left-sided ligamentum arteriosus, you have a circle around the trachea and esophagus. The circle started by ascending aorta, arch on the right side. This is the left subclavian, and this is ligamentum arteriosus. Again, we have a circle between the trachea and esophagus. Symptoms will be related to the respiratory and GIT about this. And we have here a ligamentum arteriosus that will not take a dye in the CT, but you will find indentation on the trachea. That means that this trachea compressed by this vascular ring. If you have right-sided ligamentum arteriosus, so actually we don't have a circle. Here we have ascending aorta, we have the arch and the ligamentum arteriosus on the right side. This is the left subclavian and nothing here, so we have incomplete vascular ring, and usually the patient is asymptomatic. Okay. This is how we trace the arch. This is short axis from the suprasternal view. This is the aorta in circle, and here the first branch going to the left side. This is a right aortic arch because the first branching going to the left side. This is brachiocephalic superior vena cava, and we have here aorta as a circle. This is the first branch. This is the first branch going to the left, so we expected the arch to be the opposite, so we have right aortic arch. Trace this first vessel is not bifurcating. So he gives only one vessel instead of two. So by echocardiographic in a comprehensive way, you can expect that this patient have an apparent left subclavian. Is that clear? How do we expect that? This is short axis again. This is the first branch, does not bifurcate, is going to the head without bifurcation. The first branch to the left, it means that the arch will be the opposite, arch will be right, and this not bifurcating first branch, so we expect it to have an apparent subclavian. Okay, this is multi-slice CT, very common incidental finding to have this subclavian, and again, we don't have indentation on the trachea. This means incomplete vascular ring because we don't have indentation in the trachea. Okay, we have two more types, does not relate to the arch, but to complete the story of vascular ring, we have mentioned three types by double aortic arch and apparent subclavian left or right, and the fourth one is to have pulmonary artery sling. What does mean by pulmonary artery sling? So here we have the main pulmonary, and we expect here to have right pulmonary artery, and we expect here to have the left one, but doesn't happen. Here, this is the right pulmonary artery, giving the left pulmonary artery from its side, and is going posteriorly behind the trachea, but in front of the esophagus, and going to the left lung here. Why this one is complete vascular ring? Because we have the main pulmonary artery, we have the right pulmonary artery encircled from the right side, going posteriorly here by the left pulmonary artery, and ligamentum arteriosus usually on the left side. So pulmonary sling, it is a complete vascular ring by default. This vascular ring is a peculiar vascular ring because this vascular ring encirculates only the trachea, does not encirculate the esophagus. So the symptoms here in the patient with pulmonary vascular sling will be only respiratory system. This patient gain weight, have no problem with the feeding, but you always have this patient with stridor or wheezy chest or recurrent chest infection. How do we expect that by echo? That this is the main pulmonary artery giving the right, and we find something still blue from the right. If we did a CT, you will find this one. This is main pulmonary artery giving the right, and behind the trachea you have the left one. This is how it looks like. From our cohort, we found this patient. So actually this patient, we did here this short axis. This is the aorta. This is the pulmonary. The blood going in blue color because it's going away from this from the probe, and we find here the RPA, but we couldn't find the LPA. Here again we find here the RPA, but we couldn't find the LPA. It could be an absent LPA, but if you did an extra cross imaging, you will find that, in addition to the respiratory symptoms that you expect in this vascular ring. This vascular ring do exist, but usually missed if you don't expect that. So if you have a child represented with respiratory symptoms and you didn't find the LPA, just think about this vascular ring, pulmonary vascular sling. Okay, the last type from the vascular ring is circumflex descending aorta. It's very rare, but it had been reported. What does it mean? That here we have the retroesophageal course of the descending aorta. So you have here the ascending aorta, and instead of have the arch as anterior structure, this arch will pass behind the trachea and esophagus and descended on the opposite side. So you have here the vascular ring. This is trachea and esophagus. This ascending aorta. This is the arch. This is the descending aorta. This is ligamentum arteriosus. So it's encircled both of the trachea and the esophagus. Circumflex is like what we call in the coronary circumflex. Circumflex means that it makes a circle. So circumflex descending aorta again had been reported. It's very difficult to have it by echo, but we have seen it as incidental finding in many of our multi-slice CT that we do for congenital anomalies. So this vascular ring, to recap, we have double aortic arch. This is a vascular ring that you will see it easily by contrast, encircle the trachea and esophagus. We have left aortic arch with apparent right subclavian and right ligamentum arteriosus. To make it easy, to be a complete circle, ligamentum arteriosus have to be the opposite side for the arch. So if you have left aortic arch with apparent right subclavian, ligamentum arteriosus should be right ligamentum arteriosus. Right aortic arch with apparent left subclavian. If the ligamentum arteriosus in the opposite of the arch on the left side, it will be vascular ring. Both of them are not visualized by contrast. Ligamentum arteriosus, we look intendedly for the indentation mark on the trachea, as well as the pulmonary artery sling. Pulmonary artery sling as a vascular ring gives only respiratory symptoms, not respiratory and GIT. And we have the rarest form is circumflex descending aorta. Okay. Any question about that? A bit comprehensive, but this is the vascular ring that we have as arch abnormality. Any questions about that? Okay. Some normal variant. So actually we have this as buffalo aortic arch that you have here, a main trunk that giving the right subclavian and right carotid. This is the brachiocephalic, but also giving the left carotid in that. We call it buffalo. Sometimes the buffalo will have type 1 or type 2 it's related to the origin of the left carotid. So if it's close to the aortic arch, you call it type 1. If it's a bit distance and you have a common trunk for all of them, you call it type 2. Make it easier, buffalo. It means that only the left subclavian that have a separate origin from the arch. Sorry, I call it buffalo. This is bovine. Sorry for that. This is the bovine one. Sorry for that. This is bovine type 1. Type 2, this is the buffalo, that you have a main trunk that have all the neck vessels. Again, this is normal variant, does not have any clinical implication for that. Okay. Some art in the aortic arch, we have seen it a lot by multi-slice CT. It's not for the echo, but from multi-slice CT. Usually, if you have this one, this call it Gothic aortic arch, that is have this acute angle, acute triangle. It named after the Gothic ship in the church. So we call this one with the deep angulation, we call it Gothic aortic arch. They will call this one as Romanic aortic arch. Also, it's named after the Romanic church for that. Until now, we consider it's like normal variant to describe a lot in the multi-slice CT or MRI reports, not by echo, because it's difficult to have this idea about it. Until now, no clinical implication to find a Gothic aortic arch or Romanic aortic arch. However, having said that, a lot of literature now are talking about the fluid hemodynamic in aortic arch, especially after the aortic arch repair in the coarctation or in the after arterial switch in TGA. If the babies have a Gothic aortic arch or Romanic aortic arch, many literature is coming that this is abnormal, this change in the shape might change in the fluid hemodynamic. However, it's still normal variant and does not have a clinical implication for the child. It's nice to have these figures as and these names. So if you find in the report that the Gothic aortic arch, it means acute angulation. Romanic aortic arch, this means it's wider in the aortic arch. Okay. Now we finish the anatomical abnormalities. Is it now a bit organized in your mind? So according to the anatomical abnormalities, we might have abnormal in the position, we might have supranumerosity, where is the double aortic arch represent the first vascular ring, and in the abnormal branching pattern, we have two vascular rings inside that in the apparent subclavians, beside some normal variants in the branching pattern. Obstructive lesion, as we said, that less blood went through the isthmus part during the fetal life, so it affecting the developing of the descending aorta and descending aorta. Before understanding the fetal life, I usually said how it comes to have a normal ascending aorta and to have interrupted aortic arch. How it comes. So if you didn't remember that the ascending aorta have a blood supply directly from the heart, and the isthmus is supplying the descending part, it will not be clear in your mind why the ascending aorta is that healthy and descending aorta becomes that diseased, because the blood supply in both of them in the fetal life is different. Okay, aortic coarctation, if we go more severe, it will be interrupted aortic arch or tubular hypoplasia in that. So in the aortic coarctation, Hatem in the last lecture, he went through the aortic coarctation and the theories behind it. So we will not go through it, but again. So this is the aortic part, the hemodynamic theory and the ductal theory presented in Hatem lecture. How can I think about aortic coarctation from the clinical point? Actually, aortic coarctation is very common to be present in the patient with bicuspid aortic valve and with the patient with BDA. So if you find a bicuspid aortic valve, you should document in your report that this patient does not have a coarctation. It's common association between them. How this patient present with the aortic coarctation in neonates and infants, they don't have a collateral. So once the BDA closed, the left side dysfunction with chamber enlargement, and they present with congestive heart failure. And the adulthood, because they have collateral, so actually they present mainly by hypertension, and very common finding to have a patient in the clinic that is hypertensive for a long time, resistant hypertension, and because the adult forget to do the suprasternal view, so they are not able to detect coarctation in due time. So we discovered that this patient have been a coarctation that neglected for a long time. Okay, this one of the short axis and the aorta. So you have it here bicuspid, so you have to expect and to document or exclude the presence of coarctation. How do we do that? As you might expect it, we don't do the short axis because this will not be the best option, short axis by suprasternal, but long axis by suprasternal view. It will have this ascending aorta, descending aorta, and we find an aliasing here in the descending aorta, and usually we depend on the Doppler, so we find a gradient with the diastolic tail, so we diagnose by coarctation. By this, not only the only view that we can expect coarctation by it. If you start in a segmental way, that you do the subcostal views in that, so we will find this is the subcostal view, this is inferior vena cava, and this is the pulsatility of the aorta, and you will find the pulsatility of the abdominal aorta dampened. So actually you have to expect coarctation from your first view, and this is common practice in the pediatric cardiology. They do the subcostal views and they document good pulsatility of descending aorta, and this means that presence of coarctation is very unlikely. Is that okay? So you have suprasternal view in longitudinal sector, and you have this subcostal view with diminished flow in that. Some clinical point. I said that usually we diagnose coarctation by pressure gradient across the aortic coarctation. Okay, when does not it work? That we have a coarctation without significant gradient with it. Yes, exactly. If you have aortic coarctation with VSD, because all the flow will go preferentially to the lung and less flow will go through the coarctation. So actually you have a significant coarctation, but you don't have enough flow to demonstrate this narrowing inside it. So actually in that, if you have a coarctation with intact septum, you have to depend on the gradient if you have a good function. If the patient have a VSD, so actually the pressure gradient, if you depend on the pressure gradient for severity of coarctation, will be misleaded that you have low pressure gradient and you translate that to insignificant coarctation. In that case, what we should do, so we have to depend mainly on the morphology. In children, you can get good images by suprasternal view, so you can say if you are satisfied about the echo that you have, this is a clear morphology, so you depend on echo. Still, CT is your best choice to do a morphology with that, and you will go by measuring the dimensions for the ascending aorta and descending aorta. I'll mention now which score we will use. It's easier to go for Z score for all babies. So if it's less than -2, you expected that this narrowed view. But the point is, you depend on the pressure gradient, you have intact septum, and you have good function. If you have poor function, so not enough flow will go through it, and you have VSD, so flow preferentially will prefer to go to the lung and escape this narrow pathway. Okay, some clinical points also. Many of this aortic coarctation, as Hatem said in his lecture, will go for stenting. So what about the multi-slice CT and what about MRI? I would like to declare that all aortic coarctation stent is compatible with MRI. So you can send all the patients for cardiac MRI in a safe way. You don't have to ask for MRI safety for that. Some, in comparison with some mechanical valves, still all the mechanical valves are contraindicated to be in the MRI. Actually, they will vanish because all the mechanical valve implanted after 92 is compatible with the MRI, 1.5 and 43 Tesla. But we expected this question from clinician that it's compatible or not. But all stents for aortic coarctation is compatible with MRI. So you can send the patient either for cardiac or for extra cardiac reasons in a safe way. Okay, if I have a patient with aortic coarctation stent, which modality I can use, multi-slice CT or MRI? So here your imaging modality should be CT, because it will see the aortic coarctation stent in a good way, and it can tell you if the of this coarctation stent have been broken or in situ, or there is an aneurysm as complication. So actually the imaging modality of any stent is a CT, not MRI. Why not MRI? Although that I said this is compatible to be in the MRI and it's safe, it's not contraindication, but it contains some metal. It will not move from its place, but it will give a signal void. It will see it like a dark place. So we are not able to assess the stent by itself. We can assess the left ventricle, we can assess the aortic valve, but the stent itself will be a blind spot for MRI. So we are not able to measure the flow inside it, and we're not able to tell anything about the stent. So if you are following up this stent for in-stent restenosis, or for an aneurysm complication, or for a fracture in that stent, so CT is your imaging modality. However, stent are compatible with MRI for other reasons. Is it clear for that point? Because you will face this situation in clinical practice a lot. Okay. Aortic coarctation have been covered by Hatem in the last session, and I think that interrupted aortic arch may be in our next lecture, but we will go for the embryology. Interrupted aortic arch. Interrupted aortic arch is not that common disease. However, it's a critical left side obstructive lesion, and we have 3 types. So we have type 1, type 2, and type 3, and it's depending on the site where the aortic arch is interrupted. So actually type 1 here, the interrupted aortic arch after giving all the neck vessels, and this is type 1. So in type 2, which is more common, that you will find the subclavian in the descending aorta and the interrupted part including the brachiocephalic and the carotid. And type 3, which is the rarest, the ascending aorta giving only the brachiocephalic and the carotid and subclavian coming from the descending aortic arch. Okay, what is the difference between interrupted aortic arch and the critical aortic stenosis? Sometimes that you have very narrow coarctation, so we call it pinpoint or near interruption. The difference between both of them, that in interrupted aortic arch you have adductor dependent systemic circulation. So actually in all interrupted aortic arch, this is the pulmonary artery, and we have a big non-restrictive, non-obstructive duct that the giving the descending aorta. So the difference between how we call near interruption or interrupted aortic arch other pathology, the presence of unrestricted large BDA that supplied the descending aortic arch and giving here in type 2 giving it subclavian. So here this is descending aorta, and this subclavian coming from descending aortic arch, and this is the duct, and this is subclavian and the carotid coming from descending aortic arch. Okay, again it's coming from the hemodynamic theory that less blood going from the isthmus to descending aortic arch. So we have normal ascending aortic arch and normal neck vessels, but we have an interrupted segment, and the duct continue to give, like in the fetal echo, continue to give the descending aortic arch. Okay, when to be expected in that? Okay. Okay, interrupted aortic arch is coming also with other lesions like LVET obstruction, like in TGA. Usually it's presented in the first few days. Actually, it's very rare or likely to find an adult with interrupted aortic arch to come. So actually this is pediatric practice. If the duct is closed, systemic blood flow will decrease and pulmonary venous pressure will getting high, and congestive heart failure with decrease of organ function will happen. How to expect that? Actually, it's very difficult to be expected by echo. So in interrupted aortic arch, you will find an ascending aorta that giving a neck vessel, and you are not able to find an arch. So this is one of our cohort, actually one of our good pediatric cardiologists did it. So this is the pulmonary artery dilated, and we have here ascending aorta, and we have here ascending aorta with the color in that, and we have here descending aorta, but we are not able to find the arch. You understand what this? So we have an ascending aorta in that place, giving the brachiocephalic bifurcating, and we have here descending, and we are not able to find the arch, so we send it for the cross imaging, which is CT. So here we have the ascending aorta, and we have it here, and we have the duct that is continued to have the descending. So again, as we said in many of aortic lesion, CT is your imaging modality. But in mind, yeah. Okay. دي
السي تي بتاع ايوه فين البي دي؟
دي What you think it's an arch? It's actually the pulmonary artery.
Okay. عشان كده
You think this is an arch, but this is not. This is pulmonary. So it's continuing like that. What you think an arch? It's not. The arch is there. Which type is that? Type 1. Type 1. All the neck vessels is belong to the arch.
Okay.
And this is the interruption, and this is coming here to the descending aorta. Is it clear? Okay. Tubular hypoplasia. Actually, it's an obstructive physiology that may be present in the patient depending on the length and the hypoplasia and pressure gradient. How to measure the tubular hypoplasia? If the proximal transverse arch is less than 60% of descending aorta, or this transverse arch is less than 50% of diameter of ascending aorta, or isthmus is less than 40% of diameter of ascending aorta. Use whatever you would like from that, or use the Z-score for it, and you will find that Z-score, if it's lower than -2, you consider that abnormal. Okay. This tubular hypoplasia is not that common disease associated with other lesion of left obstructive lesion like mitral atresia, hypoplastic left heart syndrome, coarctation of the aorta, and how this looks like that you have here. This is the suprasternal long axis. You have here the ascending aorta. You have the arch with the neck vessel, but you find something abnormal here. And you find here abnormal flow. So we have here, this is the ascending aorta. We have here the ascending, but something has happened here. Again, multi-slice CT will show you that you have this narrowed area. Again, back to Z-score, or back to the comparison between ascending aorta and transverse arch, you will find it less than 60 or 50 or 40, according to where you compare it with the ascending aorta. You will find tubular hypoplasia. Unfortunately, nothing to be done for this patient. All the trials to stent or to surgically approach this patient have been reported with failure and higher mortality on those patients. Tubular hypoplasia is not a common disease, but just keep in mind this is an obstructive lesion and that. Okay. As I said, in many of that, aortic structure is large structure, so it attracted all the new imaging technology. So many literature now have been working on the making these models of this this and this is based on CT. So actually this model based on CT is performed in our center. So it's very easy to get this structure like a 3D modality and to plan ahead what's going for this baby and personalize the operation in that. Why the aorta? Because it's larger structure, so actually you have all the time and you have all the good imaging to image it compared, for example, by the mitral or tricuspid inside the heart. We're facing the moving of that. This technology that we have it here, this is the 4D flow. Again, it's large structure, and you can see the fluid hemodynamics inside it. A lot of publication actually there in the literature how this blood behave inside that is 4D flow. I think in a couple of years it will be in the clinical practice, but the aortic, the bicuspid aorta and the aortic arcuation and the aortic aneurysm and the interrupted aortic arch, all of them have been studied by 4D to understand what is good for this type of repair, as we can say. This is suggested reading material or the references that I depend on them to make this lecture. If we would like to summarize, keep in mind that the clinical center and take a good history is your clue to diagnose many of those. As you mentioned, if you didn't do a good echo, you will find an arch, but you will miss another arch. You will not diagnose double aortic arch. If you didn't listen carefully for the patient complaint, you will not be able to diagnose that this patient have abnormality in their arch. Echo will remain the first cardiac imaging modality to detect arch abnormalities because it's bedside. Many of cardiologists are trained of that. Keep echo in mind. Cross imaging, mainly multi-slice CT, when needed cardiac MRI, will add great help in diagnosis and follow-up. 4D and 3D modeling is coming in the practice. Keep a new literature or new reading something about it, because I think it will allow us to understand better hemodynamics of arch anomaly in the coming years. We are finished.